Welcome, everyone, to the May 10th meeting of the Board of Directors of Washington Hospital. We welcome you all here. I invite all of you to join me in the Pledge of Allegiance. I pledge allegiance to the
flag of the United States of America and to the republic for which it stands,
one nation, under God,
indivisible, with liberty and justice for all.
Cheryl, if you take the roll for
Director Stewart,
present.
Director Nicholson,
Present.
Director Wallace,
Present.
Director Yee, Director Epen.
Present.
Thank you, Cheryl. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person in the boardroom at 2000 Maury in Fremont, California. It's also accessible by Zoom. I ask that you please mute your system until each such time as you need to speak. We are recording tonight's meeting, and it will be posted on our website for future viewing. First of all, I'd invite any communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record and proceed with your statement not to exceed 3 minutes. On issues or concerns not on the agenda and within the subject matter of jurisdiction of the board, are there any members of the public who would like to speak at this meeting? Hearing none. Cheryl, are there any written communications?
There are none.
Okay, we will then move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? None? Does any member of the public want to remove an agenda item from the consent calendar? Hearing none, may I have a motion to approve the consent calendar items A through H?
Yes, Mr. President, I move that the Board of Directors approve the consent calendar items A through H.
We have a motion and a second. Cheryl, if you would take the roll, please.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Yee, Director Epen.
Aye.
That motion passes. Thank you very much. We're now ready to move on to presentations. Kimberly, if you could introduce that for us.
Thank you, Dr. Stewart. It is my pleasure to introduce Angus Cochran and Kayla Gupta. They're going to be presenting the 2023 Community Needs Assessment. I'll begin with Angus. Angus Cochran has been with Washington Hospital Healthcare System since 2006 and currently serves as Chief of Community Support Services. In this role, he is the liaison to the Service League and manages community outreach and the Health Insurance Information Service. He is also responsible for governmental relations for the healthcare system. Angus earned a bachelor's degree from UCLA and a doctorate from Columbia University. Next, I'd like to introduce Kayla Gupta. She has been with the healthcare system for a relatively short period of time. She started in 2022. As our community outreach manager, Kayla is responsible for health and wellness programming and the Washington Wellness Center. Before joining Washington Hospital, she worked with Sutter Health as a community benefit coordinator. In this role, Kayla managed the Community Health Needs Assessment and grant-making program in San Mateo and Santa Cruz counties. She earned her bachelor's degree from the University of Pennsylvania and master's degree in public health from Emory University. Kayla is married with one young son. Thank you. Go ahead, Angus and Kayla.
Thanks so much for the introduction, Kimberly. I can hardly believe it's been 3 years since we presented the last results from the Community Health Needs Assessment. But thank you to the board for taking a few minutes this playoff evening to hear the results of the 2023 Community Health Needs Assessment. So as you probably remember, we are required by federal regulation to conduct this assessment every 3 years. But just as importantly, the assessment really strengthens our ties to the community and keeps us relevant with our district residents. It also drives the strategic direction of our health promotion and education activities for the next 3 years. So what we're presenting this evening are the research findings from the health needs assessment summarizing the health priorities that we found in the district. And then from this, we'll develop an implementation plan to address those health needs. We'll return in the fall for board approval of the health improvement plan, which will lay out all the action steps to address the health disparities we discussed this evening. In past years, we collaborated with other health systems in South County to conduct the community health needs assessments. But for the last 2 cycles, we've conducted the assessment on our own, working with the consulting group Actionable Insights. Before I turn it over to Kayla, I just want to preview a couple of themes that emerged in the study for you. The first is that community members now generally take a much broader perspective on what constitutes a health need. In the past, where people were thinking about lifestyle choices and diagnoses about their health, now they're much more likely to identify broad social determinants of health, like housing insecurity and economic instability. And really, you'll see that reflected in the report tonight. Second of all, throughout the assessment, you'll also see a focus on health disparities identified for specific racial and ethnic populations. And again, this emphasis kind of speaks to a greater awareness of the need to ensure health equity for all the populations we serve. And it dovetails nicely with the hospital and the healthcare system's focus on diversity, equity, and inclusion. And then finally, you'll see that the health indicators for Union City are significantly worse than the rest of the districts. There are many causes for this, but it will clearly need to be an area of significant focus for education and prevention efforts the next 3 years. So with that, I'll turn it over to Kayla to walk through the findings for you.
Thank you so much for that introduction, Angus. It's wonderful to be with you all this evening. We do have a slide deck prepared. I'm not sure if you're able to see that on the screen right now. Angus, if not, would you be able to share that? There it is. Thank you. Okay. All right, we can go on to the next slide, please. Thank you. So in today's presentation, we'll be doing an overview of our 2023 Community Health Needs Assessment. This, as Angus said, is an analysis of all of the key health needs that we've identified in the district. We'll go through a summary of each of the needs individually, as well as a deeper dive into each of our cities that make up the district. We can move on to the next slide, please. So the CHNA is a federally mandated report that's published every 3 years. However, as a community hospital, we understand that it's much more important than just meeting a federal mandate. We understand that this is a tool that's used to help make sure that we're in touch with our community and understand fully the health needs that are affecting the residents of South County. Not only that, it plays a key role to develop all of our strategic outreach and health initiatives moving forward. So this is something that's really important to us in our work. If we move forward, we can take a quick look back at what we found in our 2020 CHNA report, where we found our top health needs to be behavioral health, housing and homelessness, healthy eating and active living, healthcare access and delivery, social determinants of health, diabetes, heart disease, hypertension and stroke, as well as respiratory health. And keep these in the back of your mind because many of these health needs also show up again in our 2023 report. Our CHNA is a report that's developed over a long time period. We began this process back in late fall of 2022, where we began getting feedback through focus groups and interviews, and 50 community members and health professionals shared what they felt were the strongest needs in the community. We then went into our statistical and data analysis, looking at key health indicators and comparing them to the county and the state. Based on these indicators and the feedback that we received from our community members, we developed a list and ranked them in order that then turned into our final report. This process was done in collaboration with our consultant group, Actionable Insights. So if you move on to the next slide, This is just an overview of our data sources. Our consultants were able to pull the most up-to-date data to create our report, with almost 60% being refreshed between 2020 and 2022. It's important to note that data collection has been impacted by the pandemic. Over the past few years, it's not been as easy to get out into the field and to have enough staffing to refresh everything. So we really did want to make sure to emphasize that this is the most up-to-date data available, and it's a challenge that's seen across all of our hospitals. Moving on to the next slide, you'll see equally important are data that we collected directly from community and health professionals. We conducted key informant interviews with 7 participants across county public health, county behavioral health, the lesbian, gay, bisexual, transgender, queer, intersex, and asexual community, as well as housing and homelessness experts. We also conducted 4 focus groups. And one thing that's really important to note this year that we had not done in years past was, with the help of an ASL interpreter, we were able to include the voice of our deaf community and capture their experience as well. Moving on to the next slide, this gets a little bit technical, so hang in with me. I do think it's still important to help explain how our health needs are determined. So we have all of these health indicators that get collected by agencies at a city, state, and county level. And all of these indicators, our data points, are associated with poor health outcomes that show disease or a health event. We can aggregate all of these data points together to demonstrate a health need overall. So for example, when we look at diabetes or obesity, we can look at number of diabetes-related ER visits, but also look at obesity rates or walkability of a neighborhood. So for this report, we're not only looking at statistical criteria that's showing a 5% or more difference from Alameda County, we're also looking at inequities by race and ethnicity, and looking at how often it was brought up by our community members, prioritizing any health needs where we saw more than half of our focus groups or interviews bring them up as a key topic. As Angus mentioned in his introduction, health now is seen in a more broad view. We were able to integrate this idea of social determinants of health, things like economic stability, the neighborhoods you live in, your education, access to healthcare throughout the entire report, and weave in these themes as we go and look at each of our health needs specifically. So let's take a look at the snapshot of our district. We see that our total service area population is right around 350,000, with Fremont making up the largest portion of our population, followed by Union City and then Newark. We have a really diverse healthcare district, with many households having limited English proficiency. And some of the most common non-English languages spoken in the area are Spanish, Cantonese, Mandarin, Hindi, and Tagalog. If we move on to the next slide, we'll see that the race and ethnicity of our healthcare district looks very different from Alameda County and California as a whole. We have a much larger Asian population. And we do understand that Asian is a blanket term that encompasses many races and ethnicities. So the makeup of that Asian population might be different in some of our district cities, where in Union City, it could be a larger Filipino population, and in Fremont, it may be a larger South Asian or individuals of Chinese ancestry. But it is interesting to see how we differ from the county and California overall. Looking over time, we do see that the 4 largest racial and ethnic groups in the district has changed. We're seeing a significant increase in the size of our Asian population and a noticeable decline in our white population, which is now the 3rd largest demographic group for the district. While not prioritized directly in this report, COVID-19, it's really important to acknowledge the impact that it's had on the health of our community. Right now, we're still understanding exactly what all those health impacts are. We're still watching things as they emerge, but we can say with certainty that the pandemic has exacerbated national health disparities, affecting our populations of color, women, those without college degrees, and those of lower income the most. One opportunity that did come out of COVID-19 was collaboration. And Washington Hospital really stepped up to the plate and worked collaboratively with organizations across the district in direct response to COVID-19. Together, we were able to vaccinate over 44,000 adults and act as a true trusted source of information about the pandemic. So now we get to reveal what the community health needs are from our 2023 study. These are what were found to be most pressing in the community. So the top 8 most important health needs prioritized by the community are behavioral health, housing and homelessness, economic security, diabetes and obesity, heart disease and stroke, healthcare access and delivery, respiratory health, and cancer. And this order was determined by our community members. We went and asked them to rank them during our interviews and our focus groups. All of the health needs listed here are statistically significantly different from the county or show racial and ethnic disparities. Digging a little deeper, I just want to mention that community voice plays a huge role in our CHNA report. And so these highlighted health needs, behavioral health, housing and homelessness, economic security, and healthcare access and delivery were specifically called out by our focus group members and our community members throughout the entire research process. So now we get to dig into the heart of the issue and look at each health need in more detail. So we can move on to the next slide, please. Our first health need is behavioral health. This was mentioned in every single focus group and key informant interview. And we know that COVID-19 has had a large impact on behavioral health. Many of our community members talked about a lack of access to behavioral health services as something that they were highly concerned about. And we also see these racial inequities throughout, with certain populations having higher rates of alcohol and drug use, as well as serious psychological distress. As we move on to the next slide, you'll see a table, and you'll see this sort of replicated throughout the presentation as we walk through, where certain boxes are shaded a little bit darker than others. And these are indicators where we see a difference that's 5% or worse than Alameda County. So these are areas where we see opportunity for improvement. When we look at our health indicators that point to difficulties with behavioral health, we see that it's distributed across the entire district. And we also clearly see an opportunity to address drug and alcohol use in Union City and Newark, as well as opportunities to address depression with our school-aged population in Union City. Moving on to our second health need, housing and homelessness. Unfortunately, homelessness is something that we've seen almost double in the last 3 years in the district. Again, this is something that's been highly impacted by COVID-19, where the pandemic decreased emergency shelter capacity. We're also seeing racial inequities here, where Black residents are overrepresented in the population. Moving on to the next slide, you'll see a quick look at the increase in homeless population throughout the district. For a healthcare system, this means that we're likely treating more patients who are unhoused. And while we can't solve the homelessness crisis, we can play a key role in linking these patients to services after they leave our care. Our third need is economic security. This is something that was mentioned in all of our focus groups with the community, with many individuals voicing fear and anxiety around losing housing due to economic difficulties or the sharp rise in the increase of food costs. We're seeing racial inequities here as well, where our Black, Indigenous, people of color are having lower incomes and a larger proportion of individuals living in poverty. And I want to bring up those differences that we see by racial and ethnic group, because when you look at economic security at the aggregate, at the city level, everything looks like it's trending in the right direction. We see that median household income for the district is rising. And for all 3 cities, it's significantly above the county average. However, when we dig a little bit deeper, and you'll see that on this next slide, and we show a breakdown by race and ethnicity, it really showcases the inequities that exist across the district. There's a significant economic insecurity across the board for all racial and ethnic groups, except for our white and Asian populations. The majority of the earning power in our district is held by our white and Asian residents, who also tend to have higher levels of education. Our fourth health need is diabetes and obesity. While this was not directly mentioned by the community, many individuals talked about social determinants of health related to this health condition, such as access to healthy food or an interest in recreation programs. So it was really on their mind, just not as the disease state itself. Again, we're seeing that for diabetes and obesity, we also have racial inequities that exist for our minority populations. We can see what the data says in the next slide. I mean, the good news is that when we compare this to what we saw in our 2020 CHNA, ED visits and hospitalizations for diabetes has declined for the county and the district. County diabetes ED visits declined 43% and hospitalizations 12% between 2017 to 2020. We did see similar declines in Newark and Union City. However, the incidence of diabetes continues to be significantly higher than the county overall. So we still have work to do. We also see that diabetes is more prevalent in our Asian and our Black communities. Our fifth need is heart disease and stroke. And with this health need, we've got good news and bad news for our cardiovascular conditions. The good news is that mortality from stroke in Fremont and Newark is declining. The bad news is that stroke deaths in Union City are trending up, even reaching levels above the national healthy people benchmark set by the CDC. In fact, across the board, Union City is suffering more from hypertension, cardiovascular disease, and stroke than the county as a whole. This is in part because the county has shown significant improvement, but Union City is falling even further behind the county. Some indicators have improved, others have worsened, but in all cases, the disease incidence for these conditions is worse than the county average. So clearly, we see that there's an opportunity to work in Union City on health education and prevention with heart disease and stroke. And we can't overlook Newark either, where the incidence of ED visits for hypertension is greater than the county average. Our sixth health need is healthcare access and delivery. And this is something that was brought up a lot by our community members. Some common themes that came up in this discussion were challenges in communication, not just for our non-English speakers, but also our non-verbal residents, so our deaf and hard of hearing community. We heard a large call for increased cultural competency, using proper language, involving family members where culturally relevant, offering care in native language. So these are all themes that were brought up multiple times by community. If we move forward, we can see how this breaks down by race and ethnicity, where we do see pockets of disparities. Only 2/3 of Pacific Islanders have health coverage compared to the county average of 93%. And 94% of Native Americans report delaying care or having difficulty obtaining care. Our seventh health need is respiratory health. Respiratory health was not directly mentioned by the community, but it did meet the statistical threshold for a health need when compared to the county due to the disproportionate impact we're seeing in Union City. In our previous 2020 CHNA, Newark showed high rates of asthma hospitalizations. However, in this new updated 2023 report, we have seen improvement. So there is some good news with respiratory health. And our eighth and final health need is cancer. Cancer rates across the entire district for all races and ethnicities on the aggregate are not worse than the county. But again, this is another example when you dive a little bit deeper and you break down the data to look by racial and ethnic group, that's where we begin to see these disparities arise that paint a much deeper picture of what's going on. So here we're seeing white women in our district are 28% more likely to have breast cancer. Black men are 55% more likely to have prostate cancer, and the incidence of all types of cancer among white district residents is 47% greater than the county average. So to wrap up our presentation on the data from our 2023 CHNA, we've aggregated the disease incidence data for each of the 3 cities that the district encompasses. And so for each of these 25 disease states in the CHNA, the chart here shows the prevalence of the condition in the city compared to Alameda County averages. All of the bars that point to the right are showing disease states with greater prevalence than the county average. And all of the bars to the left are showing less prevalence than the county. So here on this slide where we see Fremont, we can see that the incidence of all 25 disease states is below the Alameda County average, which is great news. That being said, however, we do see that the incidence of diabetes and cardiac-related conditions is still towards the top of this chart, near the county average. So there's still work that we can do, important work that we can do in Fremont. The good news for Newark is that only 4 of the disease states are greater than the county average this year. We can compare this to 2020, where we saw 11 disease states greater than the county average. So that's quite a significant improvement. However, we're still seeing disproportionately high levels of ED visits and hospitalizations for diabetes, and hypertension is also showing, meriting some additional focus, given the levels that we're seeing in Newark as well. And our last city we'll look at is Union City. So unlike Newark, the overall health of Union City has failed to really keep pace with the county. Back in 2020, there were 12 disease indicators that were worse than the county benchmark, and this time we're seeing 13 indicators worse. So again, worse indicators that are worse than the county are the bars that are pointing to the right. We're seeing greater prevalence of cardiac-related conditions and diabetes. So this brings us to our next steps for our 2023 CHNA report. Today we'll ask for a board action to accept the findings of our report, which will then allow us to publish our final report by June 30th. We'll then take this report and share it out with all of our district cities to get feedback that we'll use to create a health improvement plan that we'll bring back to you all at the board to review in the fall. Before I wrap up, I would just like to acknowledge the individuals that made this report possible. Our consultants, Jen and Melanie, my colleagues, Elisa and Donald, and also the direction and support of our leadership through Kimberly and Tina. So this concludes our presentation. I'm happy to answer any questions you might have, and I would like to kindly request the board to vote and accept the findings contained in our 2023 Community Health Needs Assessment.
Am I on now?
Yes.
Kayla, thank you very, very much. That was a very fascinating report with lots of very, very interesting items. It'll be fascinating to see what kind of programs come out of this report. Very, very interesting. Each time those come out, I think we're surprised a little bit by how they change and how they impact the area here that we all live in. Are there any other comments or questions from the board?
Yeah, a lot of food for thought and food for work.
A lot of food for work.
I had one question, Caleb. I mean, it's a great report. Looking at the homelessness, which has been going up everywhere, but it was shown that in Newark it has gone down significantly. Do you know if there's any explanation for that?
No, it's definitely something we can look into more. When we look at our homeless counts, it's done as a point in time. So there's many factors that might, affect the data that they collect. But that's something that I can definitely look into some more, see if we can get a better answer for you and get back to you.
Thanks.
Thank you again, Kayla. At this point, I'd like to take out of order the motion to accept the findings of the Community Health Needs Assessment.
Yes, Mr. President, action item A, Community Health Needs Assessment. Mr. President, I move that the board accept the finding contained in the 2023 Community Needs Assessment.
Second.
We have a motion and a second. Cheryl, if you take the roll for us.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Yee, Director Eapen.
Aye.
Thank you very much. That motion passes. Again, congratulations on that report. Very, very fascinating. At this point, we're ready for a construction update. Is Ed Thayen with us at this point? Looks
Yes,
like
he
he
is.
is. There he is. Ed, welcome.
Thank you. Let's see, Shri, can you bring up the PowerPoint? Okay, so if you could just go back one slide, please. So we gave our last report on this back in February. You might remember that we talked about 20 different piers being placed over in the area where that truck is shown, and you've got 2 columns there. That's where we're going to focus the majority of our conversation today. That's where the most of the work is done. But before we get into the update, where we left it was 20 different piers being drilled, and then the rebar and concrete being placed in these piers about 20, going down about 25 feet underneath the ground. So let's move forward, and we'll show you what's been happening in the 3 months since the last report. Next slide, please. So the next thing that's going to be happening in this project is the existing structure of what was the old loading dock actually is going to be shored up because of the excavation that's going to be going on next to the existing buildings, and the considerable amount of concrete in the pier caps and then the columns that are going to go on here that are going to be supporting the bridge. So you may not have expected this, but the next couple of slides are going to show excavation work right along the grid line of the existing building that had to be shored up before the construction would continue forward. So you can see the beginning of excavation of that wall. Next slide, please. And then you can see the beginning of the excavation that's happening for the pier caps. But on the left-hand side, that's just pulling dirt out from underneath, because the supports that are going to go down there underneath this existing building are going to go down 18 to 25 feet. Next slide, please. Part of the work was hand dug, and you can see the workers getting pretty far down there in terms of the piers that are having to go down. Next slide, please. Rebar going into place. That styrofoam is part of the load test that's going to have to take place before the structure is complete. Next slide, please. And then concrete poured to form the new supports. Next slide, please. And then this is where each support that's been dropped has to get load tested so that they're sure that it's going to be able to take the weight of the building on each of these piers. Next slide. And that gives you a look at the 9 columns basically that are under the existing building, holding it in place before we start the excavation. You can see 2 of the drilled piers sticking up next to the building. That's how close they're coming in. And now the excavation is going to take place around it. The wood in between the structures or those structural supports is just lagging to keep dirt from falling down into that space under the building. Next slides, please. So here's the beginning of the excavation for the pile caps. So the piles have been driven. You can see the top of 4 of them there. And then this is going to be the concrete pile cap that is going to be tied to all the piers. That's then going to be the support for the columns. Next slide, please. This gives you a shot of what I would call the mid pile cap. So the one we were just looking at was on the westernmost pile, and or pile cap, being excavation for the pile cap. And these are the piers, okay, some of the piers that have been drilled. And then this is the location for the mid pile cap that's going to be put in place. One thing I want to point out to you, and the next picture is going to be even better. Look at that structure in the middle of the second of the picture on the right. That is a steel girder that is holding up the communication duct bank that we talked about last time, that we could not, that's the tie-in for Epic, and did not want to move that. You can see it's encased in concrete. Now they had to excavate underneath it, and this structure was in place to hold it in place while that excavation took place. Next slide, please. This gives you a little bit better look at what's going on there. So that's the communication duct being held up in place. Next slide, please. Okay, now you can see they're putting down here, this is in the, I believe this is in the west pile cap. So this is the first part of the pile cap being poured. This is called the rat slab. That's a slab that's put down to sort of stabilize things. The square in the middle is where the column is going to be placed. That's going to be one of the two columns that you saw in the opening picture that's going to support the whole bridge. And so it's going to tie together, the pile cap ties together the piers and the main column that's going to go up. And all that together functions as the structure to hold up the bridge. Next slide, please. Okay, here you can see the main columns that are being lifted and put in place in the pile caps. Next slide, please. Okay, once these two structures or rebar columns are put in place, we now go through a process of adding additional rebar to tie in all the different pieces of the pile cap, the piers, and the columns, so that the weight gets transferred amongst all of those structural members. Next slide, please. So again, you can see two different shots this is of the middle pile, and middle pile cap and middle column. That's closest to the entryways to the loading dock. Okay, next you can see the rebar being built up around all that structure to get ready for concrete. Again, rebar shots of that area. Next slide, please. Again, build up. This is now of the mid pile cap. Again, build up of the rebar, getting ready to tie in all the members to get ready for concrete pour. Next slide. Okay, that's the look before of the whole area before we do the concrete pour. Next slide. This gives you a shot of the concrete getting poured actually that just gives you a shot of both main columns and the mid pile cap and the west pile cap. Next slide, please. There you've got sort of a finished product once that pile cap has been poured, and you've got the columns remaining. Next slide, please. Okay, on the left, this gives you an idea of then the concrete being poured around the communication bank or duct that we talked about that was hanging there before and being supported by that steel. You can see a lot of the straps removed, and now they're building up the underground. And then you see the west pile cap, that sort of final look once the concrete has been poured there as well. Next slide, please. These are the molds for the structure, for the column structure that are going to be poured down the road here. And they're on site already and getting prepared to be put over the rebar. Next slide, please. Okay, this shows you then the fill that's going in, again, in and around that communication duct, so that on the slide on the right, you can see that gets entirely covered. And then that will be paved over as part of the drive into the loading dock. And you can see the mid column, the mid structure there next to that where they're laying out the gravel. Next slide, please. So this gives you sort of a look as they finish off grading the whole space. Next slide, please. And that gives you a look of as they finish off, the pile caps are in place, the columns are there for the molds and a future pour. And this will then complete the this side, the west side of the construction area, and they will then move over to the other side closest to Morris Hyman and put in one column in the same sort of process, and that would be the next phase of construction. And I believe that's it. That should be okay. Any questions?
Thank you, Ed. Fascinating to look at that. All that concrete looks like you could put the major building on top of that.
Yeah.
Any other questions from the board? What's our estimated completion date, and are we on schedule so far?
Yeah, our contracted date was around Thanksgiving, and where we've gone because of that redesign, we're probably a month late. We are still anticipating to be done by the end of the year.
Very good, thank you.
Ed, do you just
I'm
want to remind
fascinated they were able. Go ahead.
Oh, yes, Kimberly reminded me, just for the good of the public, of course, this is the first step of the all the projects that were voted on for the last GO bond election. And so this is the first of several projects that are going to take place with the taxpayer approved money. And this is step one of those projects. The next one will be the infill projects for the Morris Hyman Pavilion. But yes, I'm sorry, I should have opened with that.
Thank you, Ed. It's very informative, helpful to be updated on how that's going. I'm surprised they've moved as well as they have with all the rain we've had.
2 days of rain delay so far. So, and that's
That's
through the whole winter. That we really did. We dodged a bullet there.
That's remarkable, really is. I seem to remember a few more than 2 days of it. Anyway, thank you, Ed. Thank you very, very much.
Okay.
At this point, we're ready to move to our reports. I'd like now to hear from Dr. Hyder on the medical staff report. I saw him earlier. Dr. Hyder.
Yes. Good evening to all the board members. Good evening to everybody. So for my report, we have total physicians 610 with active physicians are 339, administrative are 1, advanced practice providers are 39, ambulatory is 98, consulting are 7, courtesy is 26, leave of absence 3, provisional active 49, provisional APP 24, provisional consulting 10, and provisional courtesy 14, and grand total of 610. So among them are anesthesiology are 30, family medicine 45, medicine is 266. This include ambulatory and courtesy everything, and OB/GYN 32, pediatrics 59, radiology 47, and surgery is 131, and grand total of 610. The other thing I want to convey to the board is the Washington Hospital dinner dance is on June 10, as we talked about it at Castlewood Country Club in Pleasanton, and for honoring Diane Martin for 2023 Ramos Cerruti Award recipient for that year, 2023. As far as the election is concerned, the Survey Monkey will, and for voting will go on May 12th, and it has to be returned by May 26th. That's my brief report.
Thank you very much, Dr. Hyder. We're all looking forward to the dinner dance. That'll be very nice.
Thank you.
Thank you.
Thank you.
Ready now for our Service League report from Sheila Vijay. Welcome.
Thank you, Dr. Stewart. Good evening, members of the district board. Greetings from the volunteers. As usual, the volunteers have been keeping very busy. For the month of April, 185 Service League volunteers contributed 1,781 hours to the hospital. Our Mended Hearts volunteers were particularly active. They talked to 30 heart patients and 11 family members and caregivers. I'm still new to this position, but as I ease into the role of Service League president, I have made it a goal to become acquainted with all the different volunteer assignments we offer, so I can either shadow or know more about them and bring them to your attention. So in April, I spent some time with the head trainer for the Surgery Liaison Volunteer Program, Ken Carlson. The Surgery Liaison volunteers provide companionship to anxious family members in the surgery waiting area while their loved one is undergoing surgery. Ken Carlson set up a very fine example for the volunteer he was training that day. She saw firsthand how he interacted with a young man who seemed very concerned and very lost. He was very young. After Ken introduced himself, the young man confided that his dad was having surgery for a very scary diagnosis. As they were talking, the dad walked in, gave his son a tight hug, and asked him to go home. The young man nodded, but left very reluctantly. It seemed like there was nothing unique about what Ken did that day or his interaction, but Ken's body language, tone of voice, and really gentle demeanor exemplify how we train our volunteers to stay calm, be very good listeners, and show empathy. On that day, during a 2-hour period, Ken and I interacted with 4 family members. Each one was unique, and each one was handled with extreme patience. During my presidential year, again, as I said, I hope to bring more examples like this of volunteers serving our patients, families, and hospital community. In closing, I do want to thank the hospital for hosting the annual volunteer recognition luncheon in April for our Service League members, foundation trustees, and other volunteers. Everyone in attendance not only enjoyed the lovely food that was provided by the hospital, but they were very appreciative of the recognition that we all got. So thank you very much for that. I am ready to take any questions if you have any for me.
Thank you very much, Sheila. I just want you to know that in my interactions with you and the volunteers this last month, it's been very, very pleasant. I admire your leadership. You're doing very, very well there. Are there any questions or comments from the board? You seem to get
I'm
off
so
easy
glad,
for-
Dr. Stewart, I'm not into construction. I would not be able to explain what Mr. Fayan did. I was just in awe. I mean, like, it was difficult. So any questions would be easy for me to answer.
Yeah, it's very nice to keep up to date with what's going on around
Yes.
us here. Yeah,
Thank you very
much. We're now ready for our quality report from Mary Boron. Kimberly, did you want to introduce Mary or?
Yeah, I'm just going to actually, Dr. Brian Smith is also going to join Mary. And before she gives the quality report for March, the quarter ending March 2023, Dr. Smith and Mary are going to give an overview of our fiscal year 24 quality indicators for the healthcare system that are being proposed. And I just want to introduce Dr. Brian Smith to everyone. And he serves as an advisor in quality and patient safety, and is also Washington's Chief Medical Information Officer. He served as the Medical Director of Anesthesiology from 2005 to 2022, where he managed anesthesia services and assisted with the reliable and safe expansion of anesthesia and operating room services. Dr. Smith is a graduate of the University of Washington School of Medicine and completed his anesthesiology residency at Stanford. He stayed on at Stanford for a research fellowship and subsequent period on the faculty doing cardiac and general anesthesia, with research on human factors in patient safety and high fidelity simulation. So I'll turn it over to Dr. Smith and Mary.
Hi, we've got some slides, I think. I'm going to briefly jump ahead of Ms. Bowron's quarterly quality dashboard and just go over the fiscal year 24 proposed hospital performance improvement priorities. I guess the first question is, why do we do this thing? I wanted to give a little background, why this exercise annually. We make lots and lots of measurements of quality, and you get a brief overview of those every quarter. This gives us an opportunity to reflect on what's going well and what needs extra work, and then gives guidance to all the departments so that their performance improvement projects can roll up into the larger entity. It gives us focus, and we find that some projects need everyone rowing in the same direction. So instead of every different department and service line doing their own little projects, we're all headed in the same direction so that we can move the needle effectively on the ones that matter the most. How do we go about prioritizing between all these competing metrics that are all really important? We make a matrix with a whole variety of potential candidate initiatives on the rows, and then assess them on a variety of different characteristics in the columns, things such as whether they're high risk, or whether they affect patients' clinical outcomes, or whether they affect patient satisfaction, for example. About a dozen or so important indicators, and then we choose the projects that we think for the next year will have the largest impact. And sorry, that's real small. You weren't really meant to read that. It was just an example of kind of what the scoring matrix looks like. You can go to the next slide. Without further ado, these are the proposed hospital-wide initiatives. There are 5 main categories. The first one is reduction of hospital-acquired conditions. So avoiding things that we definitely don't want to have happen to patients while they're under our care in the hospital, making those as rare as possible. The second category is utilization management. So we want to make sure our patients are in the hospital for as short of a time as possible to get them better and then get them back out to home, and avoiding readmissions. So getting them better and having them not come back to the hospital. The next main category is our patient safety, and includes safety culture. So having continual improvements in how people work in ways that maximize safety of our patients, and medication safety, hand hygiene are categories that fall into that area. Then we have risk-adjusted mortality, and then finally health equity. And I'll spend slightly longer on this one. It dovetails nicely with the community health needs assessment that we just heard a great talk about. It's a new category for this year on our initiatives, and it is a new national patient safety goal from Medicare and the Joint Commission. So what we're asking is that each different department and service line that presents quality metrics to us at the Quality Steering Council stratify their metrics by all the demographics that you just learned about earlier, so that we can see if there are disparities in our performance. So there's 2 bits of it. One is the community needs assessment, as you just heard. And then the second part is to look at our performance. Are there disparities in how we're performing based on different groups of population in the community? And if we don't measure those, then we won't know. So we're eager to get started on that work. And I'd like to defer any questions until after Mary's had an opportunity to give her talk as well. So I'll hand the virtual podium off to her for the quarterly report.
Thank you, Dr. Smith. Good evening, and I will be presenting the quality dashboard for quarter ending March 2023. So the data is a reflection of the months January, February, and March of this year. Starting off with infection prevention indicators, I'm happy to report that this quarter we did not have any hospital-acquired MRSA, and that is less than expected for a hospital of our size and type. Moving into catheter-associated urinary tract infections. this continues to be probably, I'd say, our biggest challenge area when it comes to reducing hospital-associated infections. We did have 3 of them this quarter. It is higher than the number predicted by 2. We had 2 more than expected. So what we've done is we've really pulled together a multidisciplinary team. We're reviewing everything with catheters that are in place every single day, working closely across all disciplines to make sure that our catheters are only in place if they're medically necessary, and when they are medically necessary, that we maintain them well daily by the care that we have on the actual catheter when it needs to be in place. So again, we're taking this very seriously. You can continue, you could see it's been sort of this waxing and waning issue, and again, it's our largest focus area right now. But I am moving into another device-related metric, which is our central lines. We are in this quarter at 0 CLABSIs, which is central line associated bloodstream infections for this quarter. I really want to take a moment to acknowledge the fact that we are just a few days shy of going an entire year without a CLABSI. And I'm knocking on wood as I say this, but it's a huge success for our hospital, especially a magnet hospital. The expectations are very high. This is a nursing sensitive indicator. To go an entire year without having a CLABSI is a reflection of our medical staff, who only places lines when they're medically necessary, our nursing staff, who takes care of dressings when we change them on the central line, and everybody documenting and communicating well on rounds, etc. So again, a huge success. But most importantly, this is an outcome metric. It means that our patients had great quality when they have to have a central line. And the outcome is that patients suffered far less harm and have suffered 0 harm for almost a year. So congratulations to the team who's been working on this. And then moving into our surgical site infections, this is another area where we've continued to have some success. We actually monitor over 35 procedures in the hospital. CMS requires us to focus on some, but we go the extra distance and we monitor a lot more. Colon surgery is, again, a high-risk procedure, 0 surgical site infections for this quarter. And again, this is multiple quarters, putting us at the 6th quarter with 0 infections. And then moving into our hysterectomies. Again, we're at 6 quarters with 0 surgical site infections. What this measures in quality is that there is a lot of data that says, that potentially surgical site infections can start in the OR. And then, of course, how well do you maintain the incision and the dressing, et cetera. So from the time this patient has the procedure all the way to where they're discharged and monitored for 30 days, the care was done so well and the OR was maintained so well that these patients who are having high-risk procedures for infections did not develop them. So again, another great measure of outcome of good quality care from that team. C. difficile is another area where we've continued to have a great deal of success. We are definitely in what we would refer to as a sustaining phase of having far less C. diff infections than expected. You can see by looking at the blue bar, which is our hospital data. This last quarter, we did have 2 C. diff infections. However, of a hospital of our size and type with our census, the CDC expected us to have closer to almost 10 infections. So that's significantly less. And this is something that's been carrying us forward for multiple quarters. This requires a lot of hands in the process of managing a patient to get an outcome like this, right from when the patient has symptoms for potentially having C. diff to recognizing when we should test, how we should test the stool. All of that process is something that we work together on. We have algorithms, we do a lot of teaching on it. This happens through medical staff committees, infection prevention committees, et cetera. And you can see a really good sustained effort. Again, this is a metric where it's really difficult for a patient to have C. diff, especially when you're here sick with other things. And so C. diff has it's just another event that we do not want our patients to suffer with. And so I think all of those efforts have been steering in the right direction. We've continued to have success in that area. And this is something that we're still full force ahead on and continuing to focus on. It's discussed every month in infection prevention committee. This data is shared weekly. Just because we've had sustained efforts doesn't mean that we're going to back off. Even 2 is too many for us this quarter, and those are taken seriously and we look at those. So we'll continue to keep this sustained with all of our efforts. And then hand hygiene, as you know, is something that you have to continually focus on in a hospital. How we wash our hands is the best way we can break the chain of spreading infections. It is the single most effective intervention you can do to stop the spread of infections. We are at 78% for this last quarter. That is higher than what the the World Health Organization expects for a benchmark, but which is they expect closer to 70% because that's how challenging it is to get everybody fully washing their hands. We are at 78%. However, that puts us below the Joint Commission goal. And then, of course, by our own standards, we would like to see this at 100%. We recognize this is something we need to work on. This is going through the Patient Safety Committee. The Patient Safety Committee is training people, getting new observers. We're even looking at other devices for monitoring hand hygiene, really listening to the frontline staff about when they don't wash their hands, why. And we need to learn from those people to create our action plan moving forward on what we can do to create the best situations so that they always are reminded and recognized of washing their hands. So we'll continue to work on that through the Patient Safety Committee and with Kristen Ferguson, our Patient Safety Officer. Moving into more nursing census indicators, starting off with our falls. This is a metric where, again, we've been for multiple quarters under the benchmark, including this one quarter, putting us at 0.36 for our rate for falls. But what I think is more important about this is talking about the fact that this is a reflection of 6 falls, an average of 2 each month in this quarter. And that is far less than what's expected for the population of our size and type. But it's interesting because when I was reviewing these 6 cases, I saw one case that I actually think is a success story. This was an 88-year-old who came in confused, a very high risk for falling, and the nursing staff and probably nursing assistants and everybody working on the unit recognized that this patient needed a safer bed. We use a bed that's called a lowboy bed, and it's a bed where the patient is placed very far down to the ground so that if they do have a fall, and a fall is defined as any unplanned descent to the floor. That's the national standard for how you define falls. So even a patient on a low bed that is very close to the ground, even if they roll out, that's considered a fall. And that is what happened in one of these cases. And the patient did not suffer any injury. They had one, I shouldn't say that, they had one minor injury, which was a bruise. But my point is, I think that case is an example of potentially preventing a broken hip or an injury to the head or something that could have been far worse. So there's some good success in here to recognize with stories like that, we actually prevented what could have been a significant injury. And then moving into our hospital-acquired pressure ulcers, same thing here, continuing to see a great deal of success. We had 0 pressure ulcers this quarter. This is a reflection of turning patients appropriately, placing them in the right bed, communicating with the staff and the nurses, communicating with the nurse assistants, a lot of help from each team member about rotating patients when they need to be, ambulating them. Food and nutrition, things like that all impact your pressure ulcers. So also a great successful metric. Moving into our readmissions, I am going to go through our readmission rates. And because we're taking the same approach with all high-risk patients, I'll talk a little bit about our actions after I go through the data. So starting off with patients who came to the hospital with a heart attack, we did have 4 patients return over the 3 months in this period of time. This obviously is more than CMS expects. They expect it to be closer to 15%, and we were at 18%. And then moving on to pneumonia. This is another challenging area for us. We did have some successful quarters. This last quarter, we've ticked back up. We had 9 readmissions out of 47 patients, putting us at 19%, which is higher than what CMS expects, with closer to 15%. And then in heart failure, which is an area that we've been working on quite a bit, we have had a steady decline here. We still had 14 patients come back over the quarter, but it is less than expected by CMS. We were at 17.9%, and the national benchmark on that is about 21%. I just talking about sort of modeling what we want to do for all high-risk patients. We're really learning a lot about heart failure and what we need to be doing to prevent it for our demographic here in our district, for our patient population. And so by looking at doing order sets, following up with these patients within, 3 days after they're leaving, making sure that they have a follow-up appointment, a pharmacist calling them. All these things that we've been really focusing on for heart failure have led to a steady decrease, and therefore we're applying those interventions and have always tried to apply them to the other disease states I'm going over, but we've really focused on heart failure because it had been an issue so much for us before. As you can tell, last year this time we were at 28.6%. And then getting into COPD, this is less than expected. We did have 2 patients come back over the quarter. It gives us a rate of 12.5%, less than expected. And again, the same thing with this patient population, really looking and making sure that they have the same interventions that I mentioned prior with heart failure. Coronary artery bypass graft, otherwise known as a CABG. So a patient who comes in and has a very significant, lengthy heart procedure, and we have had a decline, but we're still not where we want to be. These are small numbers because it's just based on Medicare patients and the way that they write this metric in CMS. It's there's a lot of inclusions and exclusions, but we did have one patient, even in this population, that came back. And this patient is somebody who came back 18 days after their procedure, and they had respiratory issues. We felt like it was the right thing to do to admit them. They were managed well. When we discharged them, we made sure that they went to a SNF because we wanted to make sure that they had the extra support. And then that patient later on left the SNF and is back at home. And this is something our transitional care team is working on, is really following these patients afterwards and making sure that they're getting the good quality of care even after they leave the acute care setting. So I'm hoping that that will continue to decline and we can get that under the benchmark soon. And I think most of you realize that we have a very large service line on replacing hips and knees this quarter. When we look specifically at just CMS Medicare patients who were inpatients, we did not have any readmissions, which is great. I also want to move on to the next slide, though, because this slide's not really a reflection of our whole service line. That slide that I just showed you before is just showing inpatients. And about 10% of our patients who have a hip or a knee replaced are put at an inpatient level because we think that they require extra support. They may have comorbidities, et cetera. But there's a large part of the service line that doesn't apply to, and that's what's on this slide. And this slide gives you some insight to what happens to the majority of our patients who come here and have a knee and a hip replacement. So out of 419 patients over those 3 months, only 2 were readmitted. And that is far below the national benchmark of 4%. I mean, we were at 0.5%. So these 2 patients, when I say came back to the hospital, that means that because they weren't, most of them are outpatients, it just means that they returned those 2 patients for some service, even if it was to come back because they needed to be seen in the ED or even were admitted, they would fall into this category. But again, considering the number of patients in this population, it's really shows that we do an efficient transition of care. They do great quality pre-planning. The patients know what's happening with their care even prior to going into the into the OR. There's a really good standard here, and I think that's really reflected in the low readmission rate. Thank you. And any questions? Including questions for Dr. Smith. Thank you, Dr. Smith.
Yeah, Mary, this why do you think we continue to struggle with COUDI when we've been so successful with C. diff and CLABSI and falls and pressure ulcers? What is it about the COUDIs that we're struggling with?
I think that's such a great question because we've been asking ourselves the same exact thing, because you're right, CLABSI should be a good comparison because it's a device related, right? Very similar. You put a foreign device in, you're at risk for it getting infected from external exposure going internal, right? So you should be able to apply the same bundle and have the same outcome. One of the things that we have discovered is that these patients tend to be sicker. We look at case mix index on these patients. We do a root cause analysis on each one of the counties, and that is one thing we've noticed. We have also noticed that there is area, and one of the reasons why we know that also is because the majority of them are in our critically ill patients. One of the things that we initially looked at, of course, is does the catheter even need to be there in the first place? That should always be your first question. And we put in a nursing-driven protocol, as you know, years ago. I think it's been over 2 years ago now. And the nursing-driven protocol enables and empowers nurses to remove catheters if they meet certain criteria. So we looked at that, and there is some area for improvement in that, in patients that are sicker in critical care settings. So that's one of the areas, and the number one priority that we're looking at really is how are they being managed in critical care, as far as are they getting out as soon as they need to be. I think we need some area for improvement on that. And I think a lot of that has to do with the fact that, you know, for decades, we've all been sort of inclined to think, you know, I's and O's, right? That's a big deal when you're in critical care. And you always think you need to exactly measure it, and a catheter should be in place for critically ill patients. And we know that that's not always the case. We should take it out anyway, even if they are critically ill. There are times when they actually do not need a catheter. And I think that's the focus area. We're very lucky in this hospital to have a very well-developed CNS team. I've said this before, it's one of the best, it's the best CNS team I've seen at any hospital I've worked at. And we have a dedicated CNS in critical care who's working with our infection preventionists on this. Dr. Akawili takes this very seriously, and so does Dr. Martin. And I wish I had a better answer than that, but it's that one focus area that we're looking at where we're noticing an increased incidence. I think we need to get them out faster.
Thank you, Mary.
Mary and Dr. Smith, thank you very, very much. It's always nice to see these results. It's particularly nice to see all the progress that you've made. Very, very impressive. Thank you.
We appreciate that.
Ready now to move on to our finance report. We'll hear that from Tom McDonough.
Okay.
There he
I'll
is.
be quick so that I don't delay everybody from the Warrior game.
Probably losing anyway.
Okay, moving ahead to slide 2. Operating indicators. You can see that our actual was 165.7 on a budget of 147.2, so over budget. Combined average daily census was 175 with a budget of 158. And admissions were 906 on a budget of 816. So as we go through this report, the one thing I'll point out is a lot of this volume were due to medical cases, not surgical cases. And so the reason I bring that up is when we get to the revenue aspect of the report. Patient days exceeded budget by 574 with 5,100 versus 4,600 on budget. Observation equivalent days, 296, a budget of 343. This continues to be an area of focus for our patient care services area and the organization as a whole, and you can see that improvement there. And then average length of stay, 548, was under budget of 559 by 11 basis points. It was spot on to March year-to-date number of 548 and was slightly better than our trailing 12-month average of 559. Next slide. So as I mentioned, the volume was due mostly to the medical cases. So you'll notice that in the CMI or the CMS way of measuring acuity, you can look at case mix index 5.2 versus a 1.62 budget. You can also see that trails March year to date at 1,547 on an actual basis, and it also trails our 12-month average of 1,566. Deliveries, we had a lot of deliveries in March, 143 actual on a budget of 112. Surgical cases, 395 on a budget of 362. So we'll go through surgical in just a moment. Cath labs continued their struggle over the course of the year with a 158 over a budget of 217 or 59 short. And then outpatient visits exceeded budget by almost 1,500, 10,059 with a budget of 8,596. And then emergency visits continue to exceed budget. I think this is straight 10 months of, or 9 months of straight exceeding budget, with 5,069 total on a budget of 447. Next slide. So here we get into the utilization. You can see the surgical cases, the 395 that I mentioned, and the breakdown below. So joint replacement, 185 on a budget of 146. Neurological or neurosurgeries, 23 on a budget of 31. So about 8 short of budget. And we continue to trail budget year to date by 39. Cardiac surgical cases, 11 on a budget of 15. So we're 4 short there. But other surgical cases, we exceeded budget by 6 with 176 versus 170. Cath lab cases, 158 over 217. So we're 59 short. You can see the peripheral vascular. We are 18 short of budget at 33. We were 1 over on cardiac. Non-vascular, we were 40 under the budget at 30 on a budget of 70. And then neurointerventional, we had 5 on a budget of 7. So the thing you'll notice in the cath lab, we're down across all categories, and this is due mainly to physician recruitment, which I believe Kimberly is going to cover an update in when she covers April. Okay, productivity. As you saw, the volume was much higher than budget, so we exceeded our actual productive FTEs exceeded budget by 117. And remember, this is compared to a fixed budget, not a flex budget. I'll talk about that in just one moment. Flex means we've adjusted the FTEs for the volume, right? Adjusted staffing for the volume. And then non-productive FTEs, 185 on a budget of 135, so 50. So total FTEs, almost 1,700 versus a budget of 1,500. So we exceeded by 167. But if we look at the flex budget, which said the budget would have been 1,635, we would have only been over by 3% or 48 FTEs. So much better when compared to flex due to the volume exceeding the budget. Is there opportunity to continue to improve? The answer is yes. Still over 48. Total FTEs per adjusted occupied bed. Actual was 582 on a budget of 626. And if you look at the trailing 12-month average in the first column, that is outperformed the trailing 12-month average by 602. So again, an area of concentrated focus by the organization is paying off. Next slide. So the first thing I'll say is we're comparing the March 23 here to fiscal year to date, even though the title on the right-hand side says March year to date. Total patient revenue exceeded budget by almost $24.3 million. Contractual allowance, we have seen some softening in our payer mix, softening meaning that we had more governmental payers than commercial. So 167 versus a budget of 144. So higher than budgeted contractuals, again, due to the volume. But what I'm going to point out here is the 77.65 in the contractual as a percentage of revenue versus the fiscal year to date of 75.8. So almost 200 basis points higher. The next thing I would point out is the provision of bad debt, that we had a reclass there, which is why it says 340 compared to a budget of 36. Our actual number was around 2.1 million. So total deductions, 168 million compared to a budget of 148 million. Off about 14% or 13.7. And the total deduction, again, was 77.81 and compared to a budget of 77.09. Next slide, please. So again, this is a comparison of March 23 to fiscal year to date. The heading for the right-hand side is incorrect. The only thing I'm going to point out on this page is net operating income is 1.76 actual on a budget of 1,839, so about 77,000 off budget. So even though we had higher contractuals, our operating expenses were still higher. The volume itself allowed us to have an operating margin there. And then actual year to date is almost 6 million on a budget of 16. So our operating margin is 3.6 for the month and 1.5 for the year. Next slide. So this is the FASB look at our performance, and you will notice the numbers have changed, especially in the operating margin area and the total net income margin down below. So if we looked at the prior slide, our operating margin was 3.6 for the month when we look at it from a GASB perspective. And when we look at it from a FASB, which is what non-governmental healthcare uses as their reporting, we're at about 2.4. And then year to date for FASB, we're at a 0.2 net operating income of $1 million on a budget of 11. And net income, we're at 4 for the month on a budget of 3.7. And our net income for the year is 1.2 on a budget of 3.7. And then EBITDA is the next slide. And what this is trying to show is the cash flow generated. And the EBITDA margin for March was high. It was 11.4 on a budget of 13. Actual is 9.5 on a budget of 12.4. So you can look at the 38.8 million generated year to date and the actual on a budget of 49. And that concludes my report.
Ms. Bell, I have a question. You indicated there a reclassification of bad debt going from 2.1 down to 340. What happened there? Why was that?
I'm sorry, it was a keying error.
Okay.
Any other questions for Tom? Tom, thank you very much. Appreciate you being with us tonight remotely.
I'm sorry,
We'll
I'm
now
not there
move on.
in person.
Well, sometimes there are reasons to be away, and you certainly have one. Thank you.
Thank you.
Hospital operations report now from Kimberly.
All right, thank you, Dr. Stewart. This evening, I am going to present the April of 2023, starting with the preliminary gross revenue. As you can see, gross revenue of $183.2 million for April was below the budget by $7.8 million or 4.1%, but above April of 2022 by $1.3 million or 0.7%. Inpatient gross revenue of $99.3 million was below budget by $17.3 million or 14.9% and $3.9 million or 3.8% below April of 2022. Outpatient gross revenue of $84.0 million was above budget by $9.5 million or 12.8% and $5.2 million or 6.6% above April of 2022. Also in April, the Radiation Oncology Center had $2.8 million in outpatient revenue. In April, there were 38 COVID-19 discharges or 3 fewer cases from the prior month, but 16 more than April of 2022 at 22 discharges. Next slide, please. Looking at our key census statistics, the average length of stay of 5.17 was below the budget of 5.80 by 0.63 or 10.9%. This was also lower than April of 2022, 5.99. There were 7 discharges with lengths of stay greater than 30 days, and they ranged from 31 to 72. Excluding these outliers, the average length of stay was 4.90. Still in-house at the end of April, we had 7 patients with lengths of stay over 30 days, and they ranged from 38 to 62. Outpatient observation equivalent days at 281 were below the budget of 329 by 48 days or 14.6%. However, outpatient observation days are higher than April of 2022 by 6 days. Inpatient average daily census of 141.4 was below the budget of 152.4 by 11, but above April of 2022 average daily census of 140.5. The combined average daily census of 150.8 was below the budget of 163.3 by 12.5 or 7.7%, but 1.1 or 7.7% above April of 2022 average daily census. Moving on to the admissions trend. Admissions of 806 were above the budget of 788 by 18 or 2.3%. April 2023 admissions were 42 or 5.5% above April of 2022. And again, you'll see that most of this favorable variance has been driven by medical cases. Moving on to patient days. Although admissions are up 2%, average length of stay is down 10.9%, resulting in patient days of 4,242. This is below the budget by 329 or 7.2%. And patient days were 26 days or 0.6% above April of 2022. Adult med surg days were lower than budget by 125 days. OB, peds, and special care nursery days were higher than budget by 7. IMC days of 452 were lower than budget of 459 by 7 days. And ICU days were also lower than budget by 205 days. Moving on to our surgical trend. Again, we've still had some challenges in surgical trends. And also you'll see with cath lab. Total surgeries in April of 340 were below the budget by 9 or 2.6%. Surgeries were 33 or 8.8% below April of 2022. Inpatient surgeries at 119. We're below the budget by 16 or 11.9%, and 8 or 6.3% below April of 2022. And then outpatient surgeries at 221 were above the budget by 7 or 3.3%, but 25 below April of 2022. Moving on to our surgical activity broken down. You can see that joint replacement surgical cases were above budget by 22 or 15.8%, but were 18 or 10.1% below April of 2022. We did have 52 cases at the Peninsula Surgery Center in April. Neurosurgical cases were below budget by 8, 27.6%, and were 2 below April of 2022. Also, next, the cardiac cases were below budget by 13 or 86.7%, and were 4 or 66.7% below April of 2022. We did take a look at our cardiac volume, and we did see that referrals were down in April for cardiac surgery, but May has been showing a bigger uptick, and we've seen a lot more referrals and procedures at the beginning of May. So hopefully we're starting to see maybe some of the physicians we thought had time off in terms of that. Then going on, all other surgical cases combined were below budget by 10 or 6%, and 9 or 5.5% below April of 2022. All right, moving on to cath lab. Cath lab cases for April at 150 were 79 or 34.5% below the budget of 229, and 50 or 25% below April of 2022. Cath lab inpatient cases at 78 were 42 or 35% below the budget of 120, and 29 or 27.1% below April of 2022. Cath lab outpatient cases at 72 were 37 or 33.9% below the budget of 109, and 21 or 22.6% below April of 2022. And if you turn to the next, you can see the breakdown in terms of our cath lab activity. And again, we've talked about, especially in terms of interventional radiology cases, we are in the process of recruiting for a new IR physician that hopefully we are finishing up that recruitment, and hopefully we'll be able to begin in August or September. But we also saw that cardiac cases were below the budget by 43 or 40.6%, and were 36 or 36.4% below April of 2022. Non-vascular interventional radiology cases were below the budget by 23 or 33.3%, and were 13 or 22% below April of 2022. Peripheral vascular cases were also lower than budget by 19 cases, or 40.4%, and 13 or 31.71% below April of 2022. Then lastly, we did see positive in terms of our neuro IR cases. They were above budget by 6, and were 12 above April of 2022. So continue to see some challenges in cath lab. Moving on to deliveries, we did see a little bit of a decrease in our delivery volume. It ended up at for April of 115 deliveries, which was below budget by 5 or 4.2%, but 9 or 8.5% above April of 2022. Moving on to our non-ER outpatient visits. The visits of 8,525 were below budget by 53 or 0.6%, but above April of 2022 by 130 or 1.5%. A lot of this was driven by lab visits that were 643 or 16.7% lower than budget. Majority of this has been, we've been reducing the number of procedures that are requiring COVID testing. And so we've seen that's been that major driver in terms of the lab. It was also offset by our infusion center, which was saw an increase of 27.8% that was higher than budget, along with our cardiac rehab visits that were 122 or 20.2% higher than budget. Also, the radiation oncology center, as I've said in the past, started to operate in February as a hospital-based department. and there were 317 visits in April. And the Radiation Oncology Center, as we've discussed in the past, was not included in the budget, given that we were unclear as to the start date. Moving on to our emergency room visits, as Tom mentioned, we've continued to see very high emergency room visits. This month, we saw 4,727 that were above the budget by 258 or 5.8%, and were 541 or 12.9% above the prior year. Right, moving on to gross revenue recap. Surgical cases were below the budget by 9 or 2.6%, and revenue was below budget by 1.9 million or 5.3%. Cardiac cases, as we mentioned, were below budget by 87%. That was driving that reduction. Room and board revenue was below budget by 4 million or 10.9%. Patient days were lower than budget by 7.2%. Average length of stay was lower than budget, and ICU days, as mentioned, were also lower than budget. Deliveries were below budget by 5 or 4.2%, and revenue was below budget by 213,000 or 6.3%. Emergency visits were above budget by 258 or 5.8%, and revenue was above budget by 635,000 or 5.4%. Cath lab cases were below budget by 79, and revenue was 34.5%, and revenue was 4.7 million or 33.1% below budget. Ancillary services revenue was above the budget by 2.4 million or 2.7%, primarily due to outpatient activity, including 2.8 million from the Radiation Oncology Center, as mentioned, that is now part of the hospital departments. Moving on to the preliminary payer mix, we continue to have some challenges in this area. Government-sponsored patient revenue made up 72.1% of total gross revenue. This was higher than the budget of 71.8%, but it was lower than prior year's percentage of 74.3%. HMO was 2% of gross revenue, which was lower than the budget of 2.6%, and lower than the prior year's percentage of 2.8%. PPO was 24.5%, which was higher than the budget of 24% and higher than the prior year's percentage of 21.7%. Then lastly, private pay was 1.4% of gross revenue, which was lower than the budget of 1.6% and higher than the prior year percentage of 1.2%. Moving on to our productivity indicators, productive FTEs were above budget by 4.8 or 0.3% at 1,403. Non-productive FTEs were above budget by 37.6 or 21.1% at 216.2 FTEs. And total FTEs of 1,619.2 were above the budget of 42.4, 2.7%. Productive FTEs per adjusted occupied bed came in at 5.37. As you can see, that's lower than the budget of 5.60 by 4.1%, but higher than the prior year of 5.32 by 0.9%. I know that Tom mentioned in terms of the flex budget as compared to the volume, the total FTEs were above the budget, the flex budget, by 48.6. So we still have some additional work that we can do in terms of flexing for our productive FTEs. All right, moving on to the outpatient statistics. Overall, Whitmouth Clinic visits were below budget in April by 4,102 or 22.6% at 4,086 and at 3,814 visits below April of 2022. This is really driven by two main pieces in terms of this. First of all, we still run the COVID vaccine clinic under the Washington Township Medical Foundation, and we have seen a significant decrease in the number of tests and vaccinations that are given, and so it was below budget by 921 visits. Also, we've seen many of the physicians in the medical foundation in the last couple of months take some time off because many of them over the last few years have not been able to take much time off. So we did see primary care visits that were below budget by 15.6%. And there were 18 vacation days taken by those primary care physicians. Specialist visits were also below budget by 20.9%. And again, we had over 60 vacation days taken by physicians during that month. And looking at the DevCo outpatient visits, the total of 1,928 were below the budget by 0.1% for April, and 68 above April of 2022. As you can see, the Washington Outpatient Rehab Center volume was above the budget by 53 visits. Washington Outpatient Surgery Center was below budget by 31 or 6.3%. Peninsula Surgery Center, again, saw 52 procedures, though below the budget of 100. And lastly, Ohlone College Student Health Center had 36 visits compared to a budget of 11. All right, moving on to our key financial statistics. Days cash on hand ended at 152 days, an increase of 3 days from the prior month, but 11 days lower than the same period in the prior year. We saw that in terms of the increase in days in cash due to a number of different things that were happening. We did receive the state retention pay program funds of $2.4 million. That was 2 days. We had some investment earnings of $800,000 that was equated to about 1 day. We did have lower operating cash disbursements of about 2 days, and other higher collections in terms of certain areas that also equated to 2 days, but also saw some lower collections that offset that by 4 days. So that is sort of where we are in terms of 152 days for days cash on hand. And then our days in accounts receivable came in at 58.8, slightly above the prior month of 58.0. And our charity care came in at 310,000, and we had in charity care adjustments for April of 2023. We did have one high dollar amount case at 92,380 that represented 30% of the total write-offs for this month. And that is the report for April. Any questions?
Thank you, Kimberly. If there are any questions, move on to our calendar.
All right, I am going to start with our May Employee of the Month. It is my pleasure to introduce Johanna Page. She's an accounting associate. And I'll give a little bit of a bio on her. After interacting with patients while working in a special care facility, Johanna Page wondered how she could use her accounting degree and still feel like she was helping others. With several family members in healthcare, Johanna looked forward to accepting a role at Washington Hospital Healthcare System as an accounting associate. Though she had a Bachelor of Science degree in accounting, Johanna had minimal work experience. She was anxious to learn the many aspects of our accounting department and has accepted projects supporting accounts payable, payroll, and general ledger. Each day, Johanna is open to improving her skill set, and because of that, her manager, Maria Fuentes, describes her as someone with an excellent work ethic, committed to her team, and the success of our organization. She is a key contributor to successful audits and maintains a positive and pleasant outlook, even during busy or high-stress times. Her coworkers value both her organizational skills and her cheerful disposition. Although she may not directly interact with patients, Johanna's work indirectly impacts our patient-first ethic. Her work, including maintaining good relationships with our vendors by ensuring they are paid on time and any issues are addressed, contributes to the continued success of our hospital. Congratulations to our May Employee of the Month, Johanna Page. All right, and then lastly, I can move on to the calendar, and we can start with our past health promotion and community outreach events. If you want to bring up those slides. All right, as you can see, April 15th through the 19th, we had a number of community outreach events, starting with our Spot Skin Cancer Screening event, where we screened 23 individuals. Dr. Wood, our general surgeon with the Medical Foundation, spoke about early stage breast cancer, what you should know. He had 52 live views and 393 who accessed it later on. We also attended certain organizations. Maria Nunes did stroke prevention at Carlton Senior Living. Christy Caracappa talked about Medicare at our Sons in Retirement. And then also Dr. Suri, our palliative care physician, talked at Acacia Creek, where 31 residents attended. He spoke about understanding palliative care. Moving on, April 22nd through the 2nd, then our Washington participated in recognizing the signs and symptoms of stroke. Maria Nunez presented again at the Church of Jesus Christ Latter-day Saints in Newark. We also participated in the New Haven Day 2023 at James Logan High School, and also Go Green with us in 2023. We participated in the Earth Day celebration at the downtown Fremont Event Center and Plaza. Dr. Stella Asuko, our vascular surgeon, talked about carotid artery disease, and she had 65 live views and 242 accessed it later. I also just want to mention, I know it's this week, it's Hospital Week and Nurses Week, and I just want to pause for a minute and really want to thank our amazing staff and nurses throughout the whole healthcare system. Each and every day, they demonstrate resilience and dedication and compassion to all of our patients and their family members. And I have to say their contributions are invaluable. And it truly is a great honor and privilege to acknowledge all of our staff, wherever they work in the healthcare system, and our nurses. So thank you. Thanks to all of them. They truly, every day, serve our community. All right, let's see, moving on. These are our upcoming events. You can see in terms of May 18th, our celebration of life, and it's for cancer survivors, friends, and loved ones are invited to gather on the May 18th in Anderson Auditorium. You can see May 22nd, we will be doing diabetes education at Acacia Creek. Again, continuing with that stroke prevention and awareness is very important in terms of understanding the signs and symptoms of stroke. Maria Nunes will be presenting at Fremont Hills. Christy Caracappa will be presenting advanced directives and pulse. And then on June 3rd, we will be once again hosting our tattoo removal clinic in Washington West. We still, June 6th through the 14th, you can see we have a number of community education events with our physicians. Dr. Prasad will be talking about HPV vaccine, Dr. Suri on palliative care, Elisa Curry, our coordinator of rehab clinical programs on fall prevention at Carlton Senior Living. June 14th, Linda Antes will be talking about aortic stenosis at Acacia Creek. And lastly, Dr. Tenhold, a pediatrician, will talk about feeding your baby during the first year of life. And again, many of these are on Facebook Live and YouTube. Next. I do just want to talk a little bit about some awards and recognition. As you can see, we had a number of our physicians that were winners as Best of Fremont's Reader's Choice Awards. You can see all of those listed there, and also Washington Hospital was listed as the best hospital, and then also many of our physicians in terms of honorable mention too. So congratulations to all those physicians and to Washington Hospital. As the vaccination clinic continue to give doses of COVID vaccine, we're still just around 99,000 doses have been given, and continue to give to all age groups, as you can see here. And we're about at a little over 44,000 vaccinated adults. Next slide. Also, just want to recognize the Washington Hospital Healthcare Foundation. And as we know, we had the 36th annual golf and bocce tournament in memory of Jean Angelo Pisano that was held on Thursday, May 4th at the club at Castlewood in Pleasanton. We had around 124 golfers and also bocce ball players that participated in our first bocce ball tournament. I think right now we're still calculating exactly how much we raised, but probably between 72,000 and 80,000. So want to thank everyone who participated and who volunteered at the golf tournament. We continue to host the free charitable giving and estate planning seminars. Our next one is on June 21st at 5 p.m. in Anderson Auditoriums. And again, just want to mention, save the date for the 37th annual Top Hat Gala, which is scheduled for Saturday, October 14th at Washington Hospital. And that is my report. Oh, and we have a couple of great pictures from the golf and bocce ball fun. All right.
Thank you very much. Thank you very much, Kimberly. Golf tournament was a lot of fun and dealt well. Are there any announcements to bring before the board tonight?
There are not.
Hearing none. We are now at the end of our agenda for the evening. There being no further business, this meeting is adjourned. Thank you very much for your attendance.